How can I take out this? Can you help me take out these pictures of the students? Hide. Okay. I'm done. Go start. You will take up the thyroid this morning, okay? Where do you find your thyroid? Has this been discussed in biochemistry already? Joanne?
Sa biochem po, Doc, wala pa po. Pero sa gross anatomy po, na-discuss na po siya ni Doc Viernes.
Are you done with endocrine in biochemistry?
Not yet po, Doc. Wala pa po.
Are you done with endocrine in biochemistry? Can you answer me? Tehero.
Not yet po, Doc.
Can you unmute?
Hello, Doc? Hindi pa po, Doc.
You're wala pa. Okay, so this is the first time you'll have your endocrine. Okay. So this is the anatomy of your thyroid gland. This is, where do you find this? In your neck area, right? And this is your right lobe, left lobe, and this is your isthmus. And then this is made up of, when it is colloid inside the gland. Okay. Inside the thyroid gland are colloid. And then the epithelial cells here are cuboidal when it is active. What is the component of your thyroid gland? It has follicles, the acinus. This is the functional unit of your gland. Excuse me, because the carpenter is here. Do some repairs. The epithelium of the acinus is cuboidal, but when it is inactive, it is flat. No? But when very active, it is columnar. This one here. Okay. Then the cells with microvilli, they project into the lumen. And then there are parafollicular cells, C cells, inside the thyroid. And these C cells synthesize calcitonin. So this center of the acinus is filled with colloid. Okay. The products of your thyroid is thyroglobulin. This is the storage form of the thyroid hormone. This is found in the colloidal area. This is the matrix for thyroid hormone synthesis and the substrate for iodination. So you have your iodothyronins, T3 and T4. And the molar activity is 4:1.
Babae si Prost. Hi, Prost. Halika dito.
That somebody's microphone is unmute.
Sorry po, Doc.
Yeah. Shall we continue? Shall I continue?
Yes po, Doc. Sorry po.
Okay.
Nasa CR po kasi ako.
That's all right. It's all right. That's part of the game. So we'll go back here. These are the products, okay, of your thyroid. The thyroglobulin is the storage form of your thyroid hormone. It is found in the colloidal area. So this is the matrix for the synthesis of the hormone. And this is where iodination of tyrosine takes place. Another product of your thyroid is your iodothyronins, T3 and T4. For its smaller activity, T3 is more active than T4 by 4:1. Okay, but in this secretory ratio, when the gland secretes, what comes out from the gland is more of T4 rather than T3. So the ratio is 15, T4 is to 1, T3. So in the plasma concentration ratio will come out 2:1. Most of the T3 comes from the peripheral conversion of T4 to T3. Okay? Do you follow so far? Feel free to unmute if you have any question, or if you don't understand or you would like me to repeat the explanation. Okay, protein binding. T4 is 99 to 99.95% protein bound and inactive. Your thyroid hormone needs a binding protein to transport to the peripheral tissues, to the target tissues. So it binds to thyroid binding globulin. 75% of your T4 binds to your thyroid binding globulin. And 15 to 20% binds to thyroid binding prealbumin. And only 9% binds to albumin. These are your protein binding proteins, your transport. Only 0.05% is free, and this is already biologically active. T3, 99.5% is bound to thyroid binding globulin. Negligible fraction is bound to albumin and thyroid binding prealbumin. 5.5% is unbound. So this has more activity than your T4. How is it synthesized? So they are stimulated by thyroid stimulating hormone from the pituitary. The thyroid gland is stimulated by TSH. First step is iodide uptake, iodide trapping from the outside. This occurs at the basolateral membrane and is taken up into the cell. The sodium iodide symporter. 2 sodium to 1 iodide. They go together into the cell. Sort of, the iodine rides with the sodium. The energy used is from the sodium-potassium ATPase. The energy to take up the iodine, to trap the iodine from the outside of the cell, you know, sort of in the matrix. Pendrine chloride iodide countertransporter is found at the apex towards the colloid. Because the iodine has to be transported towards the colloidal part. So it's already in the apex of the cell. Because this is one component of your thyroid hormone. Okay. So chloride iodine counter transport. Pendrin, okay, participates in the transport of iodine towards the colloid. The normal I-131 uptake. This is a test to determine if the uptake of iodine is normal or if it is too low or too high. Okay, so we use iodine 131 to determine the uptake of iodine in the thyroid gland. Next is oxidation. Next step is oxidation of your iodine, conversion to oxidized form of your nascent iodine, or I3. This is mediated by hydrogen peroxide and peroxidase to form active iodide. Then iodination of your active tyrosine. Remember, tyrosine is your amino acid derivative of your thyroid, okay? This is amino acid derived hormone. So iodination, your tyrosine is in the colloid and the thyroglobulin. Iodination of active tyrosine, addition of iodide to tyrosyl residues of thyroglobulin. Then substrate of iodination is your thyroglobulin. Then formation of monoiodotyrosine and diiodotyrosine. Hydrogen peroxide and peroxidase enzymes also act as catalysts in the binding of iodine to tyrosine so that the binding is fast. So the synthesis of the hormone is faster. Then there is coupling, condensation of the tyrosine. The MIT plus DIT will form your T3. MIT plus MIT will form your T2. Okay. DIT plus DIT will form your T4. Two DITs. Okay. This is still peroxidase mediated coupling. So this is the reaction. Iodine plus hydrogen peroxide will form your iodide plus tyrosine will form your monoiodotyrosine, or will form your diiodotyrosine. Here, the iodine will bind. This is your tyrosine molecule. 1, 2, 3, 4, 5, 6 carbon. Okay. The iodine will bind to the tyrosine. If 2 iodine will bind, then that is already diiodotyrosine. Now, if DIT will combine with another diiodotyrosine, that will form your 3, 5, because that is, 1, 2, 3, 4, 5. Okay? So, mali pala. 1, 2, 3. 1, 2, 3, 4, 5. So that is your 3, 5, 3 prime, 5 prime, tetraiodothyronine, or your thyroxine, or your T4. Okay? And DIT, diiodotyrosine plus monoiodotyrosine, will form 3, 5, 3 prime triiodothyronine. That is your T3. Okay. Sorry. I'll have to go back. Okay. Ano ba yan? So, tetraiodothyronine. My reference here is Byrne and Levy. I think this is not very clear already. So you try to go to Byrne and Levy. Physiology. Then, this is formed as a prohormone, tetraiodothyronine, inner ring deiodination. So when deiodinase acts on the so you have your T3 and T4. If the deiodinase enzyme, so in case, for example, the body needs already the thyroid hormone, so it will pinch a little of the colloid, bring it inside, then So endocytosis of the colloid at the apex of the cell, and then hydrolysis of thyroglobulin by proteases and peptidases, and from the lysosomes, then secretion of your T4 and T3 into the blood. Control of secretion is from the hypothalamus. The hypothalamus stimulates basophils to secrete TSH stimulates the anterior pituitary to secrete your TSH. TSH stimulates the follicle to secrete the hormones. Estrogen also increases TSH secretion. Large iodide decreases T4 release. Somatostatin decreases TSH secretion. Large iodide decreases T4 release, thus decrease T4 and T3, so increase TSH. Do you get that? Large iodide. Somatostatin decreases TSH secretion. Dopamine and bromocriptine decreases also TSH secretion. This is the illustration. From the basal membrane, iodine is being transported inside. Then thyroglobulin, is formed from the endoplasmic reticulum, from the amino acids. And then this is processed into the Golgi apparatus and formed into vesicles and released into the colloidal portion. And then thyroid peroxidase will help in the formation of your thyroid hormone, T3, MIT, DIT, T3, T4. Ay, ano ba yan? So, physiologic effects of your thyroid hormone. General effect of your thyroid hormone is to activate nuclear transcription. The net result is increase in functional activity throughout the body. So, increase the BMR of cells, basal metabolic rate, except in the gonads, brain, lymph node, in the thymus, lungs, spleen, and dermis. Increases body temperature. Essential for normal lactation, normal bone growth, and maturation of the neurological tissues, especially the brain. That's why this is important when a female is pregnant. This is important in the development of the neurological tissues of the fetus. That's why it is important to have iodine during pregnancy to prevent mental retardation of the fetus. You see, because this is important in the neurological This is important in the development of the brain, and its metabolic effect is stimulate carbohydrate metabolism. It stimulates carbohydrate metabolism. The overall increase in cellular metabolic enzymes result in rapid glucose uptake by the cells. Increase glycolysis, gluconeogenesis, and the rate of absorption from the GIT and insulin in secretion. Okay, because there is rapid glucose uptake, okay, by the cells, so absorption is rapid. Thus, insulin is needed. On fat metabolism, it also stimulates fat metabolism. Rapid mobilization of fat from adipose tissues will increase free fatty acid concentration in the plasma and oxidation of fatty acids by the cells. Increased thyroid hormone decreases the concentration of cholesterol, phospholipids, and triglycerides in the plasma. So you don't get obese. Decreased thyroid hormone increases the concentration of plasma cholesterol, phospholipids, triglycerides, and excess deposition of fat in the liver. So you'll get fatty liver if you have decrease in the amount of your thyroid hormone. Hypercholesterolemia in prolonged hypothyroidism is often associated with severe atherosclerosis. Also, the individual will also become obese because fatty. Physiologic amounts potentiate insulin action, but when you say pharmacologic amounts, it is more than, okay, high levels of the hormone, okay? Pharmacologic amounts produces hyperglycemia. Physiologic amounts have protein anabolic effects, but when too much of your thyroid hormone, it will become catabolic. So the individual, instead of having well-developed, for example, muscles in the arms, hindi na. The individual will appear asthenic. Its lipolytic effect is greater than its lipogenic effect. So high thyroxine levels are associated with low blood triglycerides, phospholipids, and cholesterol, and with high plasma free fatty acids and glycerol because of its lipolytic effect. This is the direct and indirect effect of thyroid hormone on cardiac output. The indirect effect probably is more important. The thyroid hormone increases heat production. So CO2 is increased in tissues, and this will go to the decreases the peripheral vascular resistance and decreases diastolic blood pressure. This is a reflex because it will increase adrenergic stimulation. Ay, ano ba yan? What happened? Because my, oh, I cannot see my, what do you call this? My arrow. Yeah. So the direct effect is, the overall effect is in increased cardiac rate and output because there is increased adrenergic stimulation. The direct effect of your thyroid hormone is increased cardiac muscle, myosin heavy chain, your alpha and beta ratio. Then increase sodium potassium ATPase and sarcoplasma calcium ATPase. Your beta adrenergic signaling is also increased, and your G protein stimulatory and inhibitory ratio is increased. And there is increased ventricular contractility and function. Thus, there is decrease in your peripheral vascular resistance. So the overall effect is increased cardiac rate and output and increased blood volume. Okay. Regulation of secretion is three-tiered, using the three-tiered pattern: hypothalamus, pituitary, and thyroid gland. From the hypothalamus comes the thyrotropin releasing hormone. Then from this stimulates the anterior pituitary to secrete your thyroid stimulating hormone. This is a tropic hormone. And this one, you're from this hypothalamus, then your TSH, and then this TSH will stimulate your thyroid to produce the T3 and T4. Your MIT and DIT will be recycled. If your hormone is needed by the body, for example, so it will pinch a colloid from the colloidal area and then bring it inside, and the lysosomic enzymes will act on it, and then the deiodinase enzymes. Deiodinase acts on the MIT and the DIT, because the T3 and T4 will be released to the outside, to the blood, okay? And the DIT, by nature, it is not us who will recycle. The thyroid also will recycle. It's MIT and DIT. The iodine in the MIT and the DIT will be acted upon by the deiodinase enzyme, and the iodine will be brought back to the colloidal area for recycling. So they will use it again. You see? If nature recycles, why not us? We have to recycle. We have to recycle our grocery bags. But sometimes, Filipinos, famous for recycling food. Ang ulam sa breakfast, if there is still leftover, ay ang ulam na rin sa lunch. O, di ba? Ganon ang mga Pilipino, matipid. Just like nature. Nature is also, nature also recycles. So your iodine and in your DIT is recycled. Okay. Now it produces thyroxine, the thyroid. Then, if there is already enough level of your thyroxine, it will exert a negative feedback on the hypothalamus to decrease release of your TRH, thyrotropin releasing hormone. Okay, so that small amount of TSH will be produced by the anterior pituitary, and the thyroid also will decrease its production of your thyroxine. Okay. Hypothyroidism. When you have low amount of your thyroid hormone. So these are the signs and symptoms. Cold intolerance, low, slow mentation. Bugo ba? Cannot easily understand. Then there is weight gain, decreased reflexes, husky voice. So it doesn't mean that if you have husky voice, it's always romantic. It could mean hypothyroidism. Then there is growth retardation, cretinism in children, and myxedema in the adult, mainly due to iodine deficiency. That's why in the market, we can now find iodized salt, okay? Because salt is used in the trapping of the iodine. So we have iodized salt. In hyperthyroidism, there is heat intolerance, nervousness and tremors, good appetite, but doesn't gain weight. No? So you have to observe, why do you have good appetite but doesn't have weight gain? Then there is increased reflexes, palpitations, fatigue, exophthalmos. Exophthalmos because there is deposition of fat in the orbitals. And so this is a very pathognomonic sign of Graves' disease. So the eyeball will protrude. So the hyperthyroidism is mainly due to long-acting thyroid stimulator. This is an immunoglobulin. How do you test for nervousness or tremors in the hyperthyroid individual? You just extend your hand and place a piece of paper. Let the patient extend his or her arm and put a piece of paper on top of the dorsum of the hand, and you can see the tremors if there is any. Okay. The condition when the thyroid is enlarged is called goiter. This is TSH, or long-acting thyroid stimulator, is present. Goitrogenic substances increases TSH secretion. And your perchlorate and your thiocyanate, they block iodide trapping. Your propylthiouracil and your methimazole, its action is iodotyrosine coupling block. And if you have excess iodide, then that is already 100 times normal, and so your goiter can enlarge. Iodide deficiency can also cause enlargement of goiter. This is the appearance of your thyroid gland when there is goiter. And can you see this? A normal 6-year-old child here on the left, and a congenitally hypothyroid 17-year-old child from the same village in an area of endemic cretinism. Usually, this is found in very high, very elevated mountainous areas already, where salt is deficient. Note here the short stature of the 17-year-old child. Obesity, malformed legs, and dull expression because there is mental retardation. Other features are a prominent abdomen, a flat, broad nose, hypoplastic mandible, dry, scaly skin, delayed puberty, and muscle weakness. Can hardly move. The child can hardly move. And this is an X-ray film of the hand of a normal 13-year-old child and that of a 13-year-old suffering from hypothyroidism here. Note that the child with hypothyroidism has a marked delay in the development of the small bones of the hands. Here in the growth centers of the fingers and in the growth center of the distal end of the radius. Here. Whereas this is already well developed in a normal child. Do you have any question? Because that would be the end of our topic for today. Yeah, this one. This is pinching off of the colloid and then brought inside and then acted upon by the lysosomal protease enzymes, and the MIT and the DIT is recycled. Your T3 and T4 is released to the outside. Okay. What else? Here, inner ring deiodination. So there is inactivation. This will be acted upon by your deiodinases type 3. If the iodination is in the outer ring, so there is the T3 form is active. And this is what you call your inner ring deiodination, is called your reverse T3. Okay, we're done so far. And by the way, do you notice there is something wrong with our schedule? With our schedule, we will have a long quiz on the 19th, right? Then on Monday, we will discuss your adrenal cortex. Next week is adrenals, pancreas, and parathyroid. Okay? And then reproductive after the holiday on the 13th. 13th is Idul Fitr. After the long quiz, do you notice that there is a repeat? There is something wrong here. This is supposed to be already in preparation for the group reporting, because you will have to do another reporting for the second semester. And so I will assign it next week. Okay. Do you notice that chapter 78, 79, 80 is repeated after the long quiz, right? That is not supposed to be like that. We will just, next week, we will correct this, okay? So, do you have any questions so far? And you read your Harper on endocrine, because the enzymes are there. And they are important, okay, in understanding the actions of the hormones. Okay. Tapos na tayo. It's only 11:20. But we're done. Sige na. What else? Wala na.